Let us discuss regarding the different surgical options of carcinoma esophagus. As far as surgeons are concerned, the mainstay of management in carcinoma esophagus is surgery. So let us discuss regarding the different types of surgical management. So what are the different surgical options? The different surgical options include transhiatal esophagectomy, transthoracic esophagectomy, en-bloc esophagectomy, minimally invasive esophagectomy. So whatever may be the different types of esophagectomy, there are some of the few basic things which happens in the esophagus and the stomach. One is you have to mobilize the lower part of esophagus and the stomach. Then we have to make the stomach into a tube, into the replacement conduit. The stomach is made into a tube. Then we have to mobilize the thoracic esophagus. Then we have to resect the tumor and the 10 centimeter with the 10 centimeter margin, upper part 10 centimeter, lower part. Why should we take this 10 centimeter? Most of the areas in the bowel we take a 5 centimeter, and in the rectum we are only taking we are only taking 2 centimeter. Why are we taking 10 centimeter in esophagus? We have already said that esophagus has a rich submucosal plexus, and the longitudinal spread of tumor in the esophagus is more. So we are taking a 10 centimeter margin in case of an esophageal tumor. After we resect this tumor and the 10 centimeter margin of esophagus, the replacement conduit is shifted into the thorax and an anastomosis is performed with the residual esophagus. So these are the different steps in whatever may be the surgical approach. So let us see how it is done, how are the steps done in different surgical approaches. One is transthoracic approach or the Ivor-Louie approach. You can see in Ivor-Louie, first esophagectomy was performed by thorax esophagectomy. In that case, what he did was he connected a tube from the cervical esophagus and a tube, and then he resected the esophagus. Then after that, he didn't have a replacement conduit, so he connected the tube from to the cervical esophagus, and then the tube came out through the patient, and then the tube goes into the stomach. The patient expired after a few days, but that was the first esophagectomy and replacement conduit. So now the things has changed. Now it has approached the Ivor-Louie approach. In Ivor-Louie approach, what we do is that through the abdomen, first the abdominal incision is put. Through the abdominal incision, the stomach is mobilized, the lower esophagus is mobilized, the esophagus is made into a tube, the stomach is made into a tube, and through the thoracic incision, the resection of the esophagus, and finally the anastomosis in Ivor-Louie approach is made in the thorax. You have to know that now coming to the en-bloc esophagectomy or Machion esophagectomy. En-bloc esophagectomy or Machion esophagectomy is for patients who is aggressive surgery. It is done in there is also lymphadenectomy happening in en-bloc esophagectomy, especially if there is an N1. This is for more of our surgeons who are aggressive, where there is an N1 lesion or there is an N1 node. And esophagus and the node is removed. So en-bloc esophagectomy is preferred for the removal of the surrounding lymph nodes in esophagus. So through the thoracic, once the thoracic incision is put, through the thoracic incision, the mid part of the esophagus, middle of the esophagus is mobilized, and then an abdominal incision is put, and all the stomach is made into a tube, and the stomach is mobilized, and after that it is resected, and through the cervical incision, the anastomosis is performed of the cervical esophagus. This is happening in Machion esophagectomy or en-bloc esophagectomy. The next type of esophagectomy is transhiatal esophageectomy. Transhiatal esophageectomy is actually a revolutionized esophagectomy. There is only 2 incisions in the abdomen and in the cervical region. You can see the beauty of transhiatal esophagectomy. It is more felt. The surgery is more felt with hands. The surgeon is actually not seeing the fingers which is going into the thorax from the abdominal cavity. So that is more felt. The lesion, the tumor, the surrounding structures is more felt and dissected rather than seen and dissected. That is the importance of transhiatal esophageectomy or developed by Oringer. Now, the anastomosis here, all the steps are happening from the abdominal incision. The mobilization of the esophagus will be happening through the abdominal incision, and the cervical incision is put. Esophagus is mobilized from the cervical part is also mobilized, and finally the anastomosis is happening in the neck. Now time has again changed. We have reached the minimally invasive esophagectomy. In case of minimally invasive esophagectomy, whatever is done by Oringer with his hand in the abdomen, the open abdomen, it is done with a laparoscope and a laparoscopy machines. And whatever it is done in the neck with the help of a cervical incision, it is done with a thoracoscope, it is done with the help of a mediastinoscopy or a cervical esophagoscopy. That is what is happening. Now, coming to the, so even though there are, even though all these are different different techniques of esophagectomy, there are certain factors different in each of these. One is the location of anastomosis. How does these factors differs in different each of these? You can see in Ivor Louie esophagectomy or the transthoracic esophagectomy, the location of the anastomosis is in the thorax. Actually, due to the decreased mobilization, the stomach is needed only to be mobilized till the thorax. There is increased vascularity of the stomach and the chance for anastomotic leak is less. So why can't we perform Ivor Louie esophagectomy in every patient? The problem if there is leak. If there is a leak for this patient, it is catastrophic. The patient is going to die most probably. The morbidity is very high. So this is the reason why the location of anastomosis in esophageal carcinoma has been shifted from the thorax to the stomach. Even if there is a slightly more increased chance for the anastomotic leak, the anastomotic leak is manageable because instead of producing a mediastinitis, it will only produce a local wound infection or a local fistula in the neck. Now, coming to the anastomotic technique. Anastomotic technique can be two types. It can be a stapled anastomosis or a hand-sewn anastomosis. Because rather than the end-to-end hand-sewn anastomosis, staple anastomosis is better because there is a decreased anastomotic leak and there is more of a decreased chance for structure in case of a staple anastomosis. Now coming to the replacement conduit. Replacement conduit is most commonly used replacement conduit is the stomach because it is well vascularized. The stomach is a well vascularized pedicle and the most of the major vascular pedicle is the right and left gastroepiploic arteries for the replacement conduit. That means what supplies the residual stomach in stomach tube, it is the right gastric and the right gastroepiploic artery. We have to be very careful regarding these arteries. Now, that is regarding the replacement conduit. Jejunum, if there is esophagectomy, a small segment of esophagus is only resected, jejunum can be used as a conduit. If the stomach is unusable because of the infiltration of the tumor, colon can be also used as a replacement conduit. Next is a conduit position. Where will we put this? Where will we put this conduit while anastomosing with the esophagus? There are most common is the posterior mediastinal space. Posterior mediastinal space is the most common space through which we pass the gastric conduit because it is the most direct path. We can also pass it substernally or through subcutaneous position. Through subcutaneous position, it is cosmetically not good, even though functionally okay. So conduit, but anyway, the most common conduit position used is the posterior mediastinal space. That is regarding esophagus. That is regarding the treatment of esophagus. Thank you.